just point your camera of your phone onto the QR reader and join the poll, because this will be an interactive part of the talk, just to ask you questions, just to test your knowledge or make it a bit more interactive. So go ahead and do that now. You just point the camera at the QR reader and click on the link that appears. So this session is on pancreas transplantation. This is obviously not core curriculum. It's not particularly commonly taught, but you know, it's interesting, and we may have exposure to people who've had a pancreas, or people who are hoping to have a pancreas, or transplant patients in general. So it's really interesting. It touches on lots of different aspects like anatomy and immunology and some ethical aspects of it too. So I find it very interesting, and hopefully you will too. We will talk about why people get a pancreas transplant, when you shouldn't consider it, the types of donors who would be eligible, the type of recipients that we think about, what the operation entails, and how to take care of them afterwards. I can see someone's already interacted with the poll, so everybody try and do so to make it a bit more fun. So either join via the web or use your phone to go via the QR reader. Two people now interacted, so that's cool. Okay, so let's start with what the function of the pancreas is, given that this is an organ that we're transplanting. So far, 2 people have interacted. So the pancreas is an organ that has both an endocrine and an exocrine function. When it is transplanted in patients, actually, we're primarily transplanting it because of its endocrine function. The exocrine function of the organ continues. That can be a bit of a problem. Actually, the only cells that we want to be transplanted are actually the beta islet cells that produce insulin, and all the other cells are additionally transplanted, but not with any particular need. So yes, the exocrine function is primarily its digestive enzymes, amylase, lipase, and a few other enzymes. Alpha cells produce glucagon, that increases your blood glucose, and the beta cells produce insulin, which decreases your blood glucose. So that is the basic function of the pancreas. What is the general treatment of diabetes mellitus? Well, we do know that there's a number of ways you can lower your blood glucose, mainly if you're type 2 diabetic. It's your diet, it's the oral glycemic agents. But for type 1 and certain type 2s, you will require exogenous insulin therapy. And now there is a range of incredible pumps that can be controlled with your iPhone, or you can do it manually by checking your BM and giving yourself insulin. But actually there's some incredible, almost fully automated pumps. After that, you have pancreas transplantation, which is what we'll talk about today. And finally, there's another option, which is really fascinating, is islet cell transplantation. And we'll briefly talk about that as well. So these are the options that people have for diabetes. Obviously, the vast majority cope with their diabetes and live with their diabetes with a good quality of life with the first 2 options. And only a very small proportion of people go on to have the latter 2. So if there are 2 excellent treatments for type 1 diabetes, that's insulin therapy versus pancreas transplantation, actually, which one is better? What is the evidence to support one or the other? Well, this is an intentionally blank slide because there is almost no evidence being generated in major trials that compares these 2. This is the big black hole, really, in the literature. Okay, so transplantation. This is, why don't we go for another poll? So let's show the results here. So most people have got this right. So going on to the second question, what are the main indications for pancreas transplantation? Go ahead and think about that. But pancreas transplant is actually the only real cure for type 1 diabetes. And cure is something you don't get to hear about much in modern medicine, but actually it's the only treatment that reliably offers long-term insulin independence in type 1 diabetes. So that's really quite an amazing thing. First done in 1966, the pancreas is not an easily manageable organ to transplant relative to other solid organs. It's fatty, it's bloody, and it has a whole host of problems. For instance, how do you manage the exocrine function or the exocrine output, which is all these digestive enzymes? You're also transplanting along with the pancreas, you actually give the donor a section of donor duodenum as well. So that stays with the pancreas when you transplant it. And obviously that's colonized with gut flora. So there's sepsis. It's also a relatively low flow organ. You know, it's well perfused, but the flow of blood through the organ is relatively slower compared to other organs. So when you implant it into a new recipient, you do have rates of thrombosis and a relatively high rate of rejection compared to other organs. But all in all, the outcomes have improved, especially since the introduction of cyclosporin, and more recently since the use of calcineurin inhibitors for immunosuppression have really greatly improved patient survival and graft survival. Graft survival means how long the actual organ survives, censored for the patient's death. So survival at 1 year is very good, greater than 90%, comparable to kidney. Okay, so what are the main indications for pancreas transplant? Most people have gone for type 1 diabetes. That is true. Some people, only 28% went for type 2 diabetes, and we'll go on to that in a second. Hypoglycemic unawareness, correct. And 14% of you went for chronic pancreatitis. The first three are correct. Chronic pancreatitis is not an indication of pancreas transplant, but the first three are. Yes, type 2 diabetes, it's relatively fewer people go for a pancreas transplant, but we'll talk about it in a bit more detail now in a second. Prior to moving on, it's worth just discussing what the different types of deceased donor. This is a slight revision of a previous talk I've given, but for someone to donate their organ, their pancreas, they are all in all 99.9% they're from a deceased donor. So in this country, we do not do living donor pancreas transplantation, mainly because of the huge risk to the living donor. So all in all, it's from a person who's died. And there's two types of donors who have died. There's those who have died after circulatory death and those who have died following brain death. So circulatory death is when they have had a severe brain injury with no hope of recovery. Brain death is similar, but actually it's the brain stem, and they have been formally diagnosed with brain stem death by two neurologists or intensive care consultants by doing a number of brain stem death tests. So they both had severe brain injury, but the DBD, it's brain stem. So the DBDs are legally dead already, even though the heart and lung are still going up and down because of the ventilator. DCDs do eventually die once the life support has been withdrawn. The critical or most important difference is actually because the DBD is already legally dead, the operation can begin with starting to remove the organs, and then eventually asystole is induced by putting a hole in the superior vena cava and then exsanguinating. Whereas the DCDs, because you can't do an intervention like this on someone who's technically legally alive, that's not directly in their interest, they have the the life support is withdrawn, and only once death is formally diagnosed and 5 minutes has gone past to ensure that they are truly dead, only then can the operation to remove their organs can begin. So the DCDs have a period of what's called warm ischemia, where the organs are ischemic and still warm, because the ice or cold perfusion fluid has not been put into the organs yet. So DCDs are considered to be slightly lower quality in general. What happens to a deceased donor? Well, all of these are ITU patients. So initially, the ITU consultant contacts the specialist nurse of organ donation, SNOD, and the SNOD then has direct contact with the family and gains consent. Once consent is gained, NHS Blood and Transplant are informed, and a national organ retrieval service is mobilized. So the IT consultant does all the brainstem death testing. The specialist nurse of organ donation will ensure that there's no obvious contraindication to their donation. For instance, active malignancy would be an obvious one. They start the process of tissue typing by taking PBLs, peripheral blood leukocytes. The family gives consent, and they decide which organs they're going to give. NHS BT will then begin the tissue typing, and they will generate a list of potential donors based on that. And the order of the donors is to do with their matchability. But who is actually transplanted is up to the recipient center. And finally, a retrieval team goes off within 45 minutes of their phone call, and they will go and get the organs. So the types of pancreas transplant. So the majority of the case, it is a pancreas along with the kidney. So you transplant both organs together. This is primarily because end-stage renal disease, because of severe diabetes, means that you have essentially two organs that have failed. One is a kidney and one is a pancreas. So SPK is the most common form of pancreas transplantation. But if you do transplant them together, obviously this can only be from a deceased donor. But thankfully, it's only one operation. In contrast, you can have a pancreas after having already had a kidney transplant. This is kind of good because your first kidney transplant may have been from a living donor, which is a very high quality donor. So you have a very high quality kidney followed by a pancreas. Or you can have a pancreas alone. So with the SPK, so that's the kidney and the pancreas together, primarily this is for type 1 diabetes, as almost all of you have indicated.
Contact Liddell on 3478, please.
So you want to list your patient for an SPK slightly sooner than you would for a kidney alone. So their GFR is 20 or less. But essentially, the nephrologist believes that at least within 6 months, they would be needing dialysis. So not stable function with a GFR of 20, but unstable or falling eGFR of less than 20. Ideally, you have to be not obese, because the operation can be quite prolonged and challenging in obese recipients. You can, as I said, do this for type 2 diabetes, but the major difference is that actually you have to be fit enough for a very big operation. So that's the limiting factor for type 2. Pancreas after kidney, you want to ensure that the kidney transplant function that they've had previously is really nice and stable, so no issues at all, and with good function. For the pancreas transplant alone, why would we do this? And as I said, it's very, very rarely performed. And as I was at a pancreas transplant center for 4 years, we never did a single one. So that's how uncommon it is. It's primarily for people who have hypoglycemic unawareness. In other words, they have absolutely no control themselves over understanding or sensing their own hypoglycemia. And obviously this is very dangerous because they can't be left alone. Or very rarely when they have just sudden rapid deterioration in neuropathy or retinopathy. But with that, you've got to know that these people will be put on tacrolimus, and tacrolimus is nephrotoxic, and that can deteriorate their kidney function. So we would not do a pancreas transplant in recipients who are severely overweight or who have a massive consumption of insulin, because a deceased donor pancreas may not produce enough insulin for them to give them independence from insulin. So you don't want to do an entire massive laparotomy and a pancreas transplant for someone who's still going to need a bit of insulin topped up. But the most important thing is actually, are they fit? People with severe diabetes, poorly controlled diabetes, can be at risk of, cardiopulmonary disease, atherosclerosis, etc. So this does remove a huge chunk of people who may be wanting a pancreas transplant. They have to be able to survive the operation itself. Obviously, people with cancer and other things will have their life expectancy shortened anyway, and they would not be for a pancreas transplant. And finally, in severe or chronic infections where the immunosuppression is going to worsen any infections that they have. So you don't want any, chronic infections at all. Fine. So we've got a poll here. So go ahead and interact with the poll. Successful pancreas transplantation will, and you have a choice of various things to see what you think. In terms of the donor selection, what type of guys? Apologies, I'm just doing a presentation. I'm going to close this door. Apologies. Yeah, go ahead. All right. So, what type of donors do we select? So, I suppose the main message is that it's much more restricted than the kidney donors. Kidney donors can be up to 80 years old and they can even have diabetes or hypertension. Because there is a shortfall in a number of organs, for kidneys, we really are much more adventurous in terms of the type of donors that we consider. With pancreas, much more limited. So younger, they have to be younger to ensure that the pancreas works. And the other important thing is obesity in the donor. Pancreas can get quite fatty, and that can impair pancreas transplant function. So you want a donor that is also skinny. Interestingly, the donor's serum amylase, smoking status, and alcohol history does not have a significant impact on pancreas transplant function. The alcohol bit is quite surprising, but there's been a number of studies that show that alcohol consumption does not impair the quality of a pancreas. Okay, so yeah, so age is important, comorbidities, and whether they're a DCD donor, and the donor's kidney function also important. In terms of the retrieval, the pancreas is quite susceptible to ischemia. So prolonged ischemia can render the pancreas unusable. So certainly in DCDs, that's circulatory death, the life support is withdrawn and we have to wait for the patient to die. This should ideally happen within 30 minutes because whilst the patient is dying, they will have hypotension, hypoxia. And if this is prolonged death, sadly, it can render the organ unusable. Ideally, what you want is for someone's life support to be withdrawn and them to die quickly. For kidneys, you can wait up to 3 hours. But with pancreas, pancreas and liver, you can only wait between 30 to 40 minutes. Interestingly, one of the most important aspects of whether the pancreas is usable is the feel. It should feel a bit like a fillet of fish, so slightly stiff but floppy. So it's actually quite an interesting thing, is that the feel is very important. So looking at your poll, successful pancreas transplant will, and most people have chosen the first two options, which is reduce the progression of peripheral vascular disease, correct, but it will not reverse it. It will reduce the progression of retinopathy, correct. It does not necessarily reverse the loss of eyesight, but it does actually improve neuropathy. So any peripheral tingling and sensory loss can improve. Okay, moving on. So what type of recipients? This can be quite complex, but the main message really is they have to be fit enough to survive a 6-hour operation with blood loss. Even when everything seemingly goes very well, there's about 30% risk of having to take them back for a re-laparotomy. So they have a whole bunch of tests: cardiac stress tests, lung tests, echocardiogram. They may require a coronary angiogram because many of these people have had, accelerated atherosclerosis, not just because of their diabetes, but because of end-stage renal failure and possibly dialysis, which can all accelerate, cardiovascular disease. They will require a CT of their abdomen to understand the anatomy of their iliac vessels and how chalky or calcified these vessels might be. Okay, so it can be quite difficult to decide whether you're going to go for a SPK or whether you're going to try and get a higher quality kidney first, followed up by a pancreas transplant. So this all depends on what options you have, what family members you have potentially to give you a living donor kidney transplant prior to your pancreas. If you have no relatives or family, you might go straight for an SPK directly, which is obviously the national pool of deceased donors. The waiting list is short. The waiting list is less than a year for most people, and people don't have to wait for very long. There's only between 200 and 100 patients waiting for these, but the way it works is that it actually preferentiates people who are waiting for pancreas, because if you're waiting for a kidney and a pancreas, because you heparinize people after pancreas transplant, you want a kidney that works straight away. Because if it doesn't work straight away, then you're more likely to need biopsies of the kidney, and if you're fully heparinized, that makes it difficult. So you want kidneys that work straight away, so you get high quality kidneys with that offer. What does the operation entail? The operation is a transabdominal approach, which is different to normal kidney transplants, which is retroperitoneal. So you normally make a sort of a cut in the right iliac fossa or left iliac fossa and skirt around the peritoneum and go into the retroperitoneum that way. But for the pancreas transplant, you go straight into the abdomen via a laparotomy. What is actually transplanted? So before I answer that, the blood supply to the pancreas graft comes from generally speaking, is the common iliac artery, or sometimes the external iliac artery. So you do the stitch work from the recipient to the donor on the common iliac, usually the right iliac fossa. So what is the blood supply to the pancreas? Go ahead and have a go at that. That's obviously important because the transplant surgeon will be using that blood supply to revitalize or revascularize the organ. It's a tricky one. It's really complex. We've got one answer that's correct so far, but I understand your trepidation there because the blood supply is fairly complex. This is my drawing. Okay, so essentially the pancreas is interesting because there's aspects of the foregut and the hindgut. So the celiac trunk is the first main anterior branch of the abdominal aorta and supplies its blood supply to the foregut. It supplies blood to the pancreas, to the pancreatic head via the gastroduodenal artery, and it also supplies little branches via the splenic artery that goes along the superior border of the pancreas. The SMA, which is the second main anterior branch of the aorta, also supplies blood to the pancreas, again, mainly to the uncinate process or head of the pancreas via the inferior pancreatoduodenal arteries. So you have blood supply coming from both the celiac trunk as well as the SMA. This is really important because we're going to have to deal with two inflows to the organ when you transplant it. Also, if you're interested, when you do a liver transplant, in a small number of people, there is a replaced or accessory right hepatic artery coming from the SMA. This means if there is abnormal or unusual anatomy in your donor, and if the liver is going to be used, then the liver trumps the pancreas, and the liver guys get to keep the SMA. Whereas, so if there is any recurrent or replaced right hepatic artery from the SMA, then the pancreas can't be used. So how do you get the organ? The organ comes in a bucket of ice, very basic. You take it out of the ice. It's covered in preservation fluid, which is called University of Wisconsin fluid. And this is what you get. So a bit of a mess. Let's try and work out what's going on here. So we can see that is the donor's duodenum. You can just about see a pancreas in there. So there's a subtle difference in the fat. A bit more of a marbled fat look, rather, and everything else is just fatty connective tissue. So that's the pancreas in there. We've got this funny structure here that looks like it's been chewed slightly. That is the spleen. So obviously you have the splenic artery going along the superior border of the pancreas, and it eventually, so it's supplying the tail, the splenic artery, but it also eventually supplies the spleen with its blood. You can see that the spleen's had bits taken, chunks bitten off it. I just wonder if anyone can work out why that's happened. It's happened because the spleen contains many peripheral leukocytes, and this is what they use the tissue typing for, to work out the best match. So this gets sent ahead to a lab. So they take little chunks out of the spleen for the cross match of, for the HLA cross match. What else do we have? We've also got a GDA. You'll have a common bile duct that poking out. You can't quite see it, but I've just put it in yellow. So you'll find that the retrieval surgeon should put a tie on that to make it clear. But you can also tell because the lumen will have slight yellowness in it. In terms of blood supply, as I said, you'll have the splenic artery going along there. Behind there, you should have the SMA, and you may also have the GDA, the gastroduodenal artery poking out. That is tied and is not used as part of the revascularization. The head will be perfectly well perfused with just the other two vessels, the SMA and the splenic artery. Behind the pancreas, you also have the portal vein. You get a 1 centimeter portal vein. That's to give the liver graft enough portal vein. You also have the SMV, superior mesenteric vein, that needs to be tied off. And you also have the inferior mesenteric vein, that needs to be tied off to stop it from hosing in. Interestingly, you can also see a bit of adrenal that's somehow got caught in there. That's an adrenal. Because you have two inflows, what you do is you take the donor's iliac branch, so you take the common iliac with its external and internal iliac of the donor, and you use it to make a trouser graft. You stitch that to the splenic artery and to the SMA, so that when you stitch it into the recipient, you've only got one inflow here. As I said, you've tied off the IMV and SMV, and the venous outflow of the pancreas will be the portal vein, and you stitch that to the inferior vena cava of the recipient. The bile duct you tie off. That leaves a duodenum, the donor's duodenum, and you stitch that to a part of the GI tract of the recipient. Previously, we'll talk about previously, but this generally gets stitched onto the mid-jejunum of the recipient. So yeah, the outflow of the exocrine function goes to the mid-jejunum. That's in 9. 8 is the is the donor's duodenum, and this the pancreatic graft here. Here you can see it's stitched. The trouser vascular graft is stitched to the common iliac at 5, and the portal vein is stitched to the inferior vena cava. You've also got a kidney transplant here in the left iliac fossa, which is stitched, which is anastomosed to the bladder and to the external and external common iliac artery and vein. About 20 years ago, you did not stitch the exocrine function to the GI tract. You stitched it to the bladder. So old pancreas grafts were actually stitched to these recipients' bladder so that they would pee out the pancreatic enzymes. This was fine and actually was cool because you could monitor the urinary amylase to test the graft function, a really nice way of monitoring for rejection. But actually, inevitably, if their kidney transplant failed, which it does do after between 5 to 20 years, it meant that these people had no urine output, but were continuing to get exocrine function into their bladder, causing quite severe cystitis, like a chemical digestive cystitis. It's quite unpleasant. So that's why we now have the exocrine function going to the jejunum. Some people previously stitched it onto the recipient's duodenum, so high up in the GI tract, but if it leaks, it can cause intestinal failure, and you don't want it leaking. You don't want to leak from the recipient's duodenum. Likewise, the ileum is too important in terms of the absorption of important stuff like B vitamins. So just mid-jejunum is fine. Some centers stitch it onto a roux limb. That's only one center does that, but it actually works quite well. Okay. Finally, taking care of your patient. Interestingly, the pancreas starts to work almost straight away. So at that point, the anesthetist should stop the sliding scale immediately once the clamps are removed and the pancreas is revitalized with the recipient's blood. So they're instantly cured of the diabetes. Going back onto an insulin sliding scale is a surgical emergency, and it would suggest that there is something wrong with the graft and they need to go back to theatre to work out what's wrong. So they must not be on exogenous insulin therapy after the operation. The most common reason for that is pancreas thrombosis. They're almost all heparinized to avoid for pancreas graft thrombosis, so usually heparinized. The use of epoprostenol is no longer a thing because of risks that I'll come on to in a second. Any issues with in the early transplant period is either immediate CT or immediate re-exploration. They have a high rate of complications, and they return to theatre very commonly. So as I said, there is a 30% risk of having to go back if the graft's not working or if there's bleeding, and graft thrombosis threatens the survival of the graft, so it is a big emergency. I put it on a poll, see what you think. The risk of paraplegia in pancreas transplant is. So paraplegia, this is a bit of a curveball. Why would you get paraplegia, loss of function of your legs? It is a risk, so just decide what you think the risk is, and I explain why this is a risk. As I said, you've got to CT these people, so don't hold back. They're committed to a lifetime of CTing, sadly. Immunosuppression. So I'll just talk about that very briefly if people are interested. It depends on local protocols, but in this country, it is primarily triple therapy. So the maintenance of immunosuppression is tacrolimus, mycophenolate mofetil, MMF, and prednisolone, which will be weaned down to 5 milligrams a day. Tacrolimus, it's a calcineurin inhibitor, and it stops the proliferation of T cells. T cells are implicated in acute rejection, solid organ rejection, so you want to stop them from proliferating. You've also got here basiliximab and alemtuzumab. These are called induction immunosuppressant agents. You get a one-off shot at induction of anesthesia, so only one-off shot. The monoclonal antibodies use one or the other. Basiliximab is the most common. It's an anti-CD25. but more commonly alemtuzumab, better known as Campath, which is an anti-CD52, is used as a one-off shot. Alemtuzumab's probably got more of an evidence supporting it. It's also cheaper than basiliximab, so more and more people are using it. Immunosuppression is really interesting, and I could talk about it all day. Just going onto the poll, what is the risk of paraplegia? It's actually 1 in 500, a bit of a shock. This is a fairly new, fairly recent understanding, is that people can develop paraplegia because there are reticular arteries coming from the aorta to the spinal cord. And if you've got a background of diabetes, there may be atherosclerosis, a narrowing of many of the vessels in the body. So that, coupled with a long operation with periods of hypotension or bleeding, can mean that there's a watershed infarct of the spine, of the actual spinal cord. Also coupled with the fact that they're kept asleep sometimes after the operation in intensive care means that it's actually, when they do wake up, there's been a period of hypotension and infarction of the spinal cord. It's 1 in 500 risk of waking up with problems walking. So it's real devastation, because people going for a pancreas transplant are generally young, and the goal is actually for them to have quality of life and to return to work and stuff like that. Fine. Next is rejection. So this will be the last few bits of the presentation. Rejection, essentially it's hard to detect rejection of the pancreas because it's no easy way of monitoring pancreatic function. Derangement of the blood glucose is generally a late finding, and these people are not checking the blood glucose because they're no longer diabetic. So worsening glycemia is a late finding, sadly. The reason why SPKs, simultaneous kidney pancreas transplants, survive longer than pancreas alone is that when you're monitoring the kidney graft with serum creatinine, actually it's a very sensitive test for rejection of the kidney. And if the kidney and the pancreas have come from the same donor, actually you get concurrent rejection of both organs. So when the serum creatinine goes up by a little bit, it can indicate that there is rejection of the kidney and the pancreas. So the kidney acts as a sort of early warning system for the pancreas. So that's why serum creatinine is really important. You can measure serum amylase and urinary amylase, but again, serum creatinine is going to be better and earlier. If you suspect rejection of the pancreas, you should get a histological confirmation, and the patterns of rejection are very similar to that described in the kidney, and it's the BAMF criteria, if you're interested, that nephrologists use to grade and diagnose rejection. How do you treat rejection? So very briefly, it's pulse corticosteroids if it's mild or early T-cell mediated rejection. But if it's recurrent or problematic, then you may want to use anti-T-cell agents such as ATG, anti-thymocyte globulin, and for acute for antibody-mediated rejection, you use plasma exchange, so a type of sort of filtering out antibodies with IVIG, and plus or minus the use of rituximab, which is an anti-CD20, anti-B-cell monoclonal antibody. So filter out the antibodies, bind the antibodies with IVIG, and stop B cells from producing more antibodies with rituximab. Fine. There's a final poll. I'll put that up. An interesting case, just not common, but just interesting to think about. So have a look at that. 20-year-old with an SPK presents with significant upper GI bleeding within 3 months of their operation, and they've got a slightly raised serum creatinine. What are your thoughts? Have a think about that. Finally, just to tie things up, what's going on with pancreas transplant in the United Kingdom? Oxford's the biggest centre. It does about 70 a year. Guy's and St Thomas's is second at about 38 a year, so not a particularly commonly transplanted organ. The majority of pancreas transplant come from DBD, so that's brainstem dead, because they're generally considered high quality in this context. cold ischemia time. This is the time that the pancreas is sitting in a bucket of ice between the donor's hospital and the recipient's hospital. Generally, you want to keep that lower than 12 hours. You don't want the pancreas to be sitting in ice for more than 12 hours. It's associated with early graft failure. And all in all, survival is excellent. This is 10-year patient survival for those who've had an SPK. And you can see that consistently across various centers, the little black dots are the different centers, A to G, and it's all above 70% patient survival at 10 years. So patients doing pretty well. Finally, just to sum up, islet cell transplantation is a thing. It's when you take a pancreas, you grind it down, you purify the beta cells, and you infuse them under the capsule of the liver, and then they start producing insulin. But unfortunately, they disappear pretty quickly. So half of the patients who've had received a islet cell transplant only half of them have a functioning islet cell after 5 years, and after that, it's another. The half-life of that's pretty quick, so it's not reliable. So in conclusion, pancreas transplant is risky, riskier than kidney transplantation, probably a similar sort of risk to liver transplantation, but not as much probably. It is a big operation, so you've got to ensure that your patient is well enough to go ahead. This is quite limiting. So the selection of your recipient has to be very critical to ensure that actually you're doing them good rather than harm. You've got to make sure that they're fit from a cardiovascular perspective. Complications are common. All in all, it's a big undertaking, and there are very, very, very good insulin pumps that could provide excellent function. My prediction is that if we can improve islet cell transplantation, that will be better. It would, at the end of the day, you're doing a big laparotomy and putting in a big organ with an exocrine function, digestive enzymes, all just because you want the beta islet cells, seems a bit much. So if we can improve islet cell transplantation, where you just percutaneously infuse, or via the portal vein, infuse cells under the liver capsule that can make you insulin independent, I think that will be better for the future. So just to answer the question here, we said that there was a 20-year-old who had a simultaneous pancreas and kidney transplant 3 months ago, has a big upper GI bleed. Where are we going with this? So the concern is that they're bleeding from the GI tract. If there is rejection of the pancreas, generally speaking, have rejection of the donor's duodenum as well. So that's a form of GI bleed. And where did we put the pancreas? The pancreas exocrine function was stitched onto the mid-jejunum. If the pancreas is bleeding, it'll bleed into the GI tract. And if it does, it's bleeding into the mid-jejunum, which is not reachable with a normal scope. Meaning that, especially if they're within 3 months, where acute rejection of the pancreas and the pancreatic and the transplant duodenum is relatively more common. So if you do have an SPK patient who has a significant upper GI bleed, I think obviously it's fair to activate all your usual pathways by contacting gastroenterologists. But at the end of the day, I think you should also contact the patient's transplant center. In London, that would be the Hammersmith or Guy's, as the chance of them bleeding from the pancreas is pretty high, and a scope will not get there. And what they need is an operation. So I hope that was interesting. I hope it was thought-provoking. This is the link to ensure that you register your decision about whether you want to be an organ donor in the future. It's best to let your family know your wishes, as at the end of the day, they can veto it. So if you sadly pass away or you're in intensive care with something serious, and you've said you wanted to be a donor, your family can veto it and stop it from happening. So make sure you tell your family your wishes, and go ahead and sign up if you want. I talked about opt-in and opt-out one of the other talks, so I won't do that now. If there are any questions.
Ben.
Hi.
I've got a question.
Oh, good. Yeah.
I've got a couple of questions. First, given that we're able to plumb the pancreas onto the GI tract now,
yeah,
is there any research looking at pancreas transplants for people with exocrine insufficiency? And second question, do transplanted pancreas grafts get pancreatitis?
Yeah, you can still hear me, can't you? Hello?
Yes, we can hear you.
Yes. The first part of your question was, do we consider pancreas transplant for endocrine dysfunction? Correct. Hello.
Hi. Yeah. Yes. Yes.
Not at the moment. I suppose probably because it's such a big undertaking for an operation, a big laparotomy, 6 hours, blood loss, etc. That I suppose it's a risk-benefit balance. Is that at the moment, I think for many people with exocrine dysfunction of the pancreas, you can give the enzymes necessary orally, and it's relatively easy, and I suppose they're fairly effective. But no, it's not to my knowledge. It's mainly for the treatment of diabetes. Yeah. Second part of your question was, sorry.
Do we get pancreatitis for transplanted pancreas?
Yes, you can. Graft pancreatitis is concerning for rejection, first and foremost. But it is also potentially representative of other infections such as cyclomegalovirus, which is much more common in a transplanted patient. So you have to check for CMV. I would do if there is a kidney, I would ultrasound the kidney and also do a biopsy of the kidney and/or pancreas in that context. Many of the patients are on valganciclovir, which is in the prevention of CMV already, but checking viral load of CMV is part of the workup of that. You can just get generic pancreatitis for all the usual reasons as well. But rejection is probably the most important thing to rule out. I've not seen alcohol-induced pancreatic graft pancreatitis, for example. But that's probably because they're being careful. Generally, there are a cohort of people that have been asked to be sensible.
Thank you.
Any other questions? Okay.
All right. Great. Well, very great talk, Ben. Very interesting. Very interesting. Thank you so much for presenting and for preparing the talk. Okay, lovely. Thanks everyone for coming, and see you guys next week.